Hi, everyone. Thank you, Taiwo, for the introduction. So my name is Frank Iorfino from the Brain and Mind Center, as Taiwo mentioned. I'm going to be speaking to you about a few different pieces of work that we've been doing here at the Brain and Mind Center to do with youth mental health. And the populations we work with, while they're primarily youth mental health, they are largely based in secondary, post-secondary settings in universities. So highly relevant, and many of the youth mental health issues I'll be talking about are relevant to university students. So a lot of the work has to do with how we can use digital technologies in a way that improves youth mental health care for young people. So we know that, this period for young people is a critical period of onset of most major mental illnesses, with about half by age 18 and almost 2/3 by 25. And that's for all disorders having the age of onset. And then we know that disorders during this period can lead to lower workforce participation and living standards later in life, as well as reduced income and social problems with greater marriage instability. And this is even if the disorder is subthreshold or has remitted. So it really highlights the importance of early intervention and trying to reduce the impact of disorders during this period. And so at the Brain and Mind Center, we've been developing a youth mental health model, which is more youth focused, which aims to really explicitly prevent the progression to more complex and severe forms of illness and reduce the impact of disorders. But importantly, the model aims to align with contemporary models and patterns of emergence of psychopathology, as well as the types of comorbid presentations that we often see in young people and the underlying neurobiology that is driving illness. And the model also aims to leverage practices such as routine outcome monitoring, multidimensional assessment, and regularly adjusting treatment based on knowledge about the type of illness someone has and their progress. And obviously these practices, as I'll show soon, are highly supported by digital technologies, and that's where our work is focused. You can access via the QR codes any of the papers I will talk about, and this is a really critical one which highlights the Brain and Mind Center's youth model in its whole. I'll be focusing mainly on the multidimensional outcomes and the digital technology work, but there's a lot of information there about clinical staging and illness types and psychopathophysiology. So as I mentioned, we have this multidimensional outcomes framework, which it recognizes that mood and psychotic syndromes that developed in young people extend beyond the symptoms that define them. So they affect different aspects of people's lives, which are typically established during adolescence and the young adulthood period. Young people in universities are leaving sort of more dependent environments at school and at home and going into to university environments which are much more independent, maybe moving out of home. So they face many more challenges, which is why the onset of disorders during this period is common, but also has major impact and has huge impacts, which is why we see that 22 years is the age identified as having the maximum negative impact of a disabling illness. So since young people are more likely to present with these multidimensional needs, we need strategies in universities and health services to be in place to be able to identify and respond to a range of health and social issues with the appropriate type of intervention. And just to point out a few of the studies, so these are some studies that are, again, in that previous paper I provided on the previous slide. We know that about 1/4 of young people are disengaged from work or education, or up to 40% report previous self-harm, 2 to 3 times higher rates of drug and alcohol use, increased BMI. So you see that there are multiple range of social and physical and mental health issues that young people have to contend with. And so some of the work that I'll be talking about has to do with this Brain and Mind youth cohort, which is primarily a primary care level service, but it's located at the University of Sydney. It's a headspace service. It's an early intervention youth service, but it's located at the University of Sydney. So the majority of them are post-secondary students, about 65%. And so seeking help for mainly depression and anxiety, and primarily in early stages of illness. and so that paper there is a bit of a cohort profile of that population. But importantly, our work with this cohort has highlighted that many young people, the majority, tend to experience significant social and occupational impairment over a long period of time. So there's a group who have sort of stable, good functioning, but about 2/3 either get worse or have this persistent impairment. So they may be engaged, a portion of them will be disengaged from education, but a large proportion of them will be engaged, but may be experiencing impairment, days out of role, missing class and things like that, having low, not meeting sort of their level of engagement that they could be. And also there's this risk of illness progression to more severe syndromes in these populations. So our work showed that people could progress from stage 1A to or stage 1B to a full threshold disorder, which is stage 2, and that things like lower functioning, at-risk mental states, sleep disturbances were all predictors of advancing or progressing to more severe illness. And so we've been interested about how we can use digital technologies to apply the Brain and Mind Center's youth mental health model. And so this is about trying to provide personalized and measurement-based care to young people. Personalized in that it covers it uses the multidimensional framework to really understand what is going on for young people. But also is measurement-based in that, along the care journey after an initial assessment, which is quite comprehensive, tries to understand what is going on for a young person. There's routine outcome monitoring and measurement-based care used over time to identify whether someone is improving or deteriorating in their care, whether they're maybe at university, but they might disengage or aren't going to classes, keeping track of what might be going on for young people so that their care plan or the interventions allocated to them can meet their needs at any given point in time. And so this is a digital technology we've developed to try and assist with this. And so what it involves is it helps with the assessment, the management, and the monitoring of mental health and well-being. It involves a comprehensive web-based assessment to understand their needs. It goes into much more detail about their personalized dashboard or results. And importantly, people can set their priorities. So they can identify what areas of their health and well-being, their mental health, that they want to focus on. There are recommended care options, which could be online supports, as well as things that they can do with their clinician who may be located in a university or another health service. And as I mentioned, you can track progress over time across a range of dimensions to see how they may be tracking. And this is utilized in mental health services in Australia and Canada. And just a bit about the research methodologies we've used to develop and implement this. As many of you would know, working with technologies is important that co-design methodologies are used. So participant design and service mapping and education and training and user acceptance testing were all key methodologies that we've used to develop this technology. And then also many of those co-design methodologies, especially service mapping, feed into the implementation and validation approaches that we use, where we are working with services to try and implement a new technology and changes to clinical process to integrate the technology. And then there's a series of impact evaluations, so continuing to work with those services to see what is the impact through surveys, but also workshops and then semi-structured interviews with those using the technology to look at barriers and facilitators. And then finally, we're engaging more and more in systems modeling and simulation. So this is more about looking at what is the broader impact of the use of the technology in a wider health system. So that might be, how the university's services might engage with other services around the community or state-based services that might be hospitals and so on. So this is trying to look at what is the impact of our research and of something like the technology in a broader mental health system to try and identify and forecast what might happen when we make changes based on the research. And so some of our implementation research has highlighted how, it's not straightforward when you try and implement technologies into new settings. And so this work was a pre and post survey we did, one of the impact evaluations, looking at the impact on clinical processes and what clinicians thought the impact would be. And there was a polarization about the use. There was great uncertainty at baseline, but then after using the technology, there was this polarization where a larger proportion agreed that there was a willingness to implement the technology in their services, but also an increase in those who disagreed. And similarly for whether they thought it would improve health for their clients. Again, great polarization, many, two to three times more people agreed, but also about twice as many disagreed with this. And we also created uncertainty about changes to clinical processes. This is really important in terms of the research methodologies when you're working with digital technologies and trying to instigate change. We created great uncertainty about willingness to change clinical processes. And I think this really points to there being sort of different camps within the services that we worked with that had sort of differing underlying beliefs about the use of technology and how they may be applied to help young people. We're also trying to take this work to the population and a larger population. So working with workplaces and universities to try and provide a different version of the technology. So this is an Interworld platform, but it's specifically for workplaces and universities. So it has the same type of real-time assessments, same type of personalized results, but it's still multidimensional, but it focuses much more on key things that are relevant at a population level. But importantly, it adds additional content, personalized content that tries to engage people, whether it be trying to improve their daily activity or their physical health or their emotional health, providing them with links to, things to read, podcasts, psychoeducation resources, online interventions. And so this is available across a whole workplace or a whole university to try and improve the general mental health and well-being of that population. And it also allows people to put in sort of their goals and try and use habit tools and try and use activities to try and change behaviors. And what we see as being really important here is being able to make mental fitness integral to the quality of life and performance as important as physical well-being is. And so, trying to encourage people to be tracking their mental fitness as much as they would be tracking their physical health, so that we can identify when people might be at risk for developing more serious concerns in the future. So another piece of work that we've been focusing on is how we can use digital technologies to enhance decision-making and identify groups of young people who might be at increased risk in the future. And so using the Interworld platform and its comprehensive assessment, we have taken that information and tried to identify, at entry into care, can we identify young people with differing levels of needs based on the type and severity of needs they might have? We know that many of the services we work with, and I'm sure this is the same for many university settings, demand for mental health services is quite high. So being able to identify who might need increased support early on is really important. And so we've used this multidimensional approach again here. So looking at anxiety, depression, psychotic-like experiences and mania-like experiences, because we know that these at-risk mental states are really are good predictors for the progression of illness in the future, but also importantly, functioning, which is really important for people, engaged at school and work. And suicidality, which is a really critical outcome in this area. And we identified these three groups that differed in type and severity. So you can see class 1 is this sort of early stage group where they might have mixed symptomatology, but limited impacts on functioning. And that's about 23% of young people. And then there's this class 2 with significant impairment, but lower rates of these at-risk mental states and suicidality. So this is more of an established depression with functional impairment. And then the final group you can see is quite high in everything, And this is a much more complex group with great impairment, higher rates of suicidality and at-risk mental states. And when we just take a closer look at the clinical characteristics of each of these classes, I just want to point out too that the whole sample, so 65% again, were engaged with full-time or part-time study. And so, and you can see there, I've put the study, the engagement rates in study for each of the classes there as well. So that early stage group, about 70% were engaged in full-time or part-time study, versus about 63-64% in the other two groups. So you can see that even this established depression group, who tended to be older, quite a few of them still engaged in university, but have these sort of other underlying issues that may be a concern to them. But importantly, the largest group was this group here with very high and complex needs. And this group here tended to have experienced a traumatic event, have more disordered eating, and some of them may be disengaged at the time of the study in terms of disengaged from employment or training. And then there were stepwise differences. So you can see here the impacts, increased from, as we went from early stage illness to established to very high needs in terms of rates of alcohol use increasing, rates of distress, decreases in social support, and the likelihood of having a previous mental health problem. And so this is the type of stratification is something we can use to allocate different care, allocate people to different levels of care, where those with earlier stage illnesses could be allocated online interventions and supports, versus those with very high and complex needs really being suited to more intense interventions and maybe referrals out to secondary services and increased supports from drug and alcohol and other community services. And finally, I just want to end on the importance of measurement-based care and just highlight some of the key things we're doing in this area. So while we identified quite severe or sort of persistent impairment in the population in our previous work, we've also identified that when we look at individual trajectories of young people presenting to care, we can see that they're highly dynamic and difficult to predict, which means allocating interventions and for whom can be quite challenging. And so we've been engaged in trying to develop technologies and AI tools that can support decisions about who might be at risk for poor outcomes in the future, based on their trajectory of functional impairment. And so we've developed a machine learning model here, which takes into account someone's covariates and creates a cluster, puts them into clusters based on whether they think that trajectory might be up, improving, or going down, or staying the same. And then when combined with their initial functioning, so where they are, where they present, we then get a trajectory model, which then allocates or simulates what are the potential trajectories for that particular person. And what we can do here is develop, and what we have done is developed a tool with decision support tool, which can provide predicted probabilities of whether someone is in, of which class someone it might be in. So you can see here, based on these level of this information here provided from the assessment, you can see that this person has a greater high chance of staying the same, so at their level of slight impairment, but they also have a significant chance of 34% chance of deteriorating in the next 3 months. And this work here is really critical for those who might be already functioning well at presentation. So in terms of the university setting, we know if someone's engaged in university, they might have quite good functioning because they're not disengaged. But a critical question for many of the services that would be working in these settings is, well, who among this group of people functioning well might be at risk of deteriorating in the next 3 months? So who's at risk of going below a SOFAS score of 70, which indicates impairment? And we can see that based on this modeling, there are these individuals with comorbid medical problems, previous self-harm, sleep and circadian disturbances, those at-risk mental states, and more progressed stage of illness. Those individuals were at risk of deteriorating in the future. So this model is something that we are looking to use in terms of identifying who might be at risk, so we can facilitate higher early interventions and prevention strategies that might be able to prevent or delay that type of functional impairment. And what we're doing with this digital technology is trying to facilitate informed clinical decision-making in services. So rather than being reactive to change, or we're trying to be more proactive and dynamic in the ability in taking into account prognosis and individual risks for allocating interventions. And you can see the performance of the model there in terms of its accuracy is quite good in terms of 0.7 and sort of AUC there of 0.8. So I've tried to cover a whole bunch of things. I mean, many of the work I've talked about today, it's put thanks to the Youth Mental Health and Technology team here at the Brain and Mind Center, who have worked with us over the years on this piece of work. But I hope that provides a bit of an overview of the different pieces of work that we're engaged in terms of trying to develop technologies to support more informed and shared clinical decision-making for youth mental health services and improve the outcomes of young people with mental illness. Thank you.